Hello, everyone. Welcome. Thank you so much for joining. This is the second webinar of the Infection-Associated Chronic Conditions Understanding and Engagement Project. My name is Lisa McCorkle. I am the co-founder of the Patient-Led Research Collaborative and also a steering committee member of the Long COVID Alliance. This project that we'll be discussing today has been led by Karen Bischoff of the COVID-19 Longhauler Advocacy Project. If we go to the next slide, sorry. Emily Taylor of Solve M.E, Lucia Santos at Patient-Led Research Collaborative, and me. And it's really been an honor for all of us to bring together patient groups, clinicians, and researchers over the course of this project to help us build partnership amongst infection-associated chronic conditions. Next slide, please. The purpose of our webinar today is to share findings from the course of our project, to provide various perspectives across patients, clinicians, and researchers on why it is important to collaborate across IACC communities, and to illuminate how we can all work together to increase awareness, support patients, and inform research. Next slide, please. So here's our agenda for today. First, we will be covering insights from the project. Then we will have a roundtable conversation on the importance of cross-IACC collaboration. This will be with Dr. Rowe, Dr. Blitzstein, Lorraine Johnson, and Karen Bischoff. And then we'll have some time for audience Q&A. So if you have questions for the team, please put them in the Q&A box anytime throughout the webinar, and we will try to address as many as possible at the end during Q&A. Next slide, please. An administrative note is that because the project is funded through federal dollars, we cannot discuss lobbying or policy change at this webinar today. Next slide, please. And it's now my pleasure to turn it over to Lucia and Emily to give background on our project. Lucia?
Thank you, Lisa. Next slide, please, Anne. The global COVID-19 pandemic created unprecedented awareness of the long-term health implications of an infection, with tens of millions of people in the US now battling long COVID. The impact on individuals, families, and society at large has been tremendous, severely affects patient quality of life, stresses our healthcare systems, and has depleted the labor force. Long COVID shed light on the complex challenges faced by people with similar chronic conditions or syndromes that often have onset after an infection, such as myalgic encephalomyelitis, chronic fatigue syndrome, also known as ME/CFS, postural orthostatic tachycardia syndrome, also known as POTS, and other forms of dysautonomia, mast cell activation syndrome, also known as MCAS, persistent Lyme disease or chronic Lyme disease, pediatric acute onset neuropsychiatric syndrome, PANS, pediatric acute onset neuropsychiatric disorders associated with Streptococcus, pandas, and more. Next slide, please. Millions of Americans were living with IACCs prior to the COVID-19 pandemic. It's important to remember, but the exact number is unknown, as large-scale epidemiological studies identifying the number or percentage of Americans with any IACC have not yet been undertaken to date. The US population estimates of just a few IACCs published before or at the start of the COVID-19 pandemic suggest that these conditions were already widespread. Next slide, please. The term infection-associated chronic condition applies to a variety of chronic conditions that can be triggered by viruses, bacteria, fungi, or parasites. Next slide, please. It's important to note that IACCs are not new, which to me personally makes the theory of psychosomatic origins all the more ignorant. The history of IACCs illustrates the evolving understanding of how infections can have far-reaching consequences on health. Experts began to recognize that infections could leave lasting effects as far back as the 19th century with the development of germ theory following rheumatic fever outbreaks. And with post-polio syndrome, which was identified in polio survivors years after their recovery. and characterized by muscle weakness and fatigue. This drew attention to the idea that certain infections could have long-term consequences. The HIV epidemic led to studies on infections and their long-term health effects, expanding our understanding of IACCs. Research has also shown links between infections and autoimmune conditions, such as Guillain-Barré syndrome following certain viral infections. I'm going to turn it over to Emily Taylor, who is going to speak on the specifics of our project.
Fantastic. Thank you so much. It's a pleasure to be here. And thank you to all of my collaborators and co-leaders. This has been an absolute joy of a project, and I am so grateful to work with you all. Next slide, please. So for those of you who are not familiar, I'm Emily Taylor. I'm the president and CEO of Solve M.E, and I'm also one of the co-founders of the Long COVID Alliance, along with Hunter Howard and Karen Bischoff. We came together, the three of us, because we identified a common need all the way back in 2020 when we knew the pandemic was going to have a long tail of post-viral or infection-associated illness following it. That led to the formation of the Long COVID Alliance, identifying that need and then following the science to understand where that lead and that need was taking us and finding the barriers that were preventing us from uncovering the realities of that science. It was so amazing that that work within the LCA identified additional barriers and needs within the IACC community. And then the CDC Foundation, seeing those barriers as well, brought in the ICUE program. It was truly a match made in heaven where two organizations and entities representing a multitude of other stakeholders came together to collectively address these barriers and needs. During that process, we really identified that there is a subgroup of the diseases mentioned here that are neglected IACCs, infection-associated chronic conditions that have, for many reasons, not received the funding, attention, awareness, and visibility that absolutely they deserve. And that has been the core backbone of the work that we've done together. Next slide, please. As you can see, we've done a lot of work to date, and that's brought us here to the national webinar today. What I'd like to emphasize is our key themes as we've conducted this workflow. First, that we have emphasized our community engagement. We are community-led, we are patient-led, and we have centered at the forefront of our efforts and continuing through the patient voices and the community voices of the stakeholders that are really impacted by these illnesses. We are moving forward together and collectively addressing the gaps that we identified early on in the LCA and have continued to identify and drill into throughout the process of this project. Next slide, please. I'm not going to take the time to read all of these amazing organizations that have taken part in one way or another, but I just want to emphasize here, it is a big tent. As we went through the process of identifying these needs and following the science and following that science to other organizations and entities and disease spaces that are touched by this, you can see it really brought a lot of people to the table, not just the patient community, but clinical care providers, scientists and researchers, and other major players and stakeholders in the facility, especially caregivers and clinicians. And we are so grateful for everyone's contributions. They have all been extremely valuable. Next slide, please. So here I'm just going to talk about a little bit of how the workshops and the flow went through. We started with, as I described, the evidence of commonalities and gaps and barriers, and that's where we really drilled into in workshop 1. In workshop 2, we also looked at collaboration and looked at the teachable moments, the shared experiences in the clinical space that were identified, and how we could address the challenges of those shared experiences together in collaboration. We really have the benefits of looking both forward and backwards through this process, and that enable us to look at kind of the hows and whys of where we got to the current situation with the barriers and gaps that we face, and looking forward to what resources that we now can bring to the table to address those barriers, that many of which were historical and built into systems, but some were new challenges that really erupted through the pandemic and through the tsunami of new patients that have been unfortunately introduced into this community through COVID. So we had both of those perspectives, and I think that was really valuable as we moved into workshop 3. Next slide, please. what we thought was really interesting that we took from workshops 2 and 3 to really drive in here on workshops 3 and 4 was the question, what contributes or creates the clinician experiences or the patient experiences in medical spaces? That's both in the research space and in the clinical care capacity. What did those lived experience teachable moments look like from the other side of the table, from the clinical experience to the patient experience, from the researcher experience to the quote unquote subject experience? How did all of those interactions play out? That's really what we dug into in the process. And then my favorite workshop, I'll have to just pause here and say my favorite workshop was workshop 4, personally, because this is the workshop where we got to dare to dream. We took the idea of resources and limitations off the table, and we said, if you had your own magic wand and could wave it with unlimited resources in the research space, how would you solve these problems? And that was gems of information, just truly so valuable. I loved that workshop, and the results of that workshop, I think, were such a perfect capstone to the whole process that brought us into, next slide, please, workshop number 5. In workshop number 5, now that we've dared to dream, now that we've looked at lived experience, now that we've looked at shared experiences across infection-associated chronic conditions, how can we take all of that information that we gleaned from workshops 1 through 4 and build that into next steps? With this workshop, we narrowed down what was really needed and what was the priority needs that we needed most to tackle some of those big dreams we identified in workshop 4. And one area that I just really wanted to highlight here was the resource guide. This is such a great identification of a barrier, and that's one that we've started on to really drill forward. Next slide, please. So, now that we've been through 5 workshops, hundreds of participants, brought all this information together, what are we going to do with it? How are we going to take this whole process and all of the gems and nuggets of brilliant information we found from the community and the collective stakeholders and move that forward? We found these common objectives towards collective action. We want to continue and enhance cross-disease collaboration. We found immense benefits from when different disease spaces worked together, both scientifically and in the community spaces. We want to advance public awareness of IACCs. That message that Lucia shared, that IACs are not new, that still has not been completely brought up in a lot of the spaces, and that the common understanding of IACCs is still pretty limited. So this is something we feel is a top priority. We want to also promote comprehensive research. This is really ties into a broad theme about breaking down the silos and breaking down the barriers between different buckets of research. Not only is this important for research collaboration, for the findings of the research, for understanding the commonalities between IACCs, but this is also really important structurally. It avoids duplication. It ensures there's no redundancies. We don't want to be running the same studies over and over and over again. We want to do the same studies more effectively so that we can cross-collaborate and have common data elements between multiple avenues of our IACC community. The last 3, I'll just move through really a little quickly, but these are pretty straightforward. Enhancing patient and caregiver quality of life. This is so simple, and yet in terms of the words that are actually on the page, but so complex because the gray areas, the nuance, the interconnectivity of a whole person. So I want to emphasize here, when we talked about enhancing patient and caregiver quality of life, we're talking about 360-degree wraparound services, not in one context of clinical care, one context of research, or one context of home life. The whole shenanigans, the whole experience of what it is to be a patient or a caregiver, a 360 wraparound support system. Lastly, the last 2, modernizing healthcare systems. This is something that is not unique to IACCs, but definitely is something that is harming us, or a broader issue that is harming these illnesses and these disease spaces specifically. And then last but not least, clinician education. I know that this may seem very duh to so many people, but when you really dig in, and we had the opportunities in these workshops to look at both sides of the table, to really hear all the different perspectives and identify the wheres and the whys that patient education can be effective, and where's and the whys of why patient educations or clinician education up until this point has not been effective in this area. And so much more additional information that we will use to create the IACC community developed resource guide. Next slide, please. So I know there's a lot going on in this slide, so I'll just leave it there for a moment for y'all to just kind of absorb. But the big takeaway here is that the ICUE momentum has been huge. IACC is becoming a household term. We are moving to a point where there are major research conferences, major both government-funded research conferences and private research conferences that are looking at IACCs in a holistic fashion. This is phenomenal. One specific example I'd really like to highlight to just show how this has taken flight, how this flywheel is spinning up in motion, is specifically the definition recently published by the National Academies of Science, Engineering, and Medicine about long COVID. Big kudos and big congratulations to everyone who worked on that panel. It was a monumental effort, but most importantly, the element I'd like to highlight is that that definition identified long COVID first and foremost as an infection-associated chronic condition. And that was a vital, important distinction that is going to absolutely change the direction of how our research and our stakeholders are treated in the future. This is especially important in the context of neglected IACCs, the IACCs that need that additional understanding, that need that additional public awareness. So again, that I think is truly a reflection of this project's work, that you can see in real time that the awareness and the initiatives built around the IACC barriers, challenges, and concerns have taken hold and are really being effective in real time. So with that, I was a very quick summary. I'm happy to answer additional questions if folks would like to drill in a bit more deeply, but given the limited time we have and the amazing panel members we have, I'm sure you're done listening to me talk and want to get to this fantastic panel we have. So with that, I will turn it back to Anne. Thank you so much for your time and for your attention, and looking forward to our panel discussion.
Great. Thank you so much, Emily. That was really wonderful. Hello, everyone. My name is Anne Valek, and I'm a founder and managing partner at Commonality. It's been our team at Commonality's honor to be supporting the ICUE project over the last 2 years in collaboration with the Long COVID Alliance. And so I'm absolutely thrilled to be moderating this very, very important panel with you all today. As Emily just said, based upon the work of the ICUE project so far, time and time again, it has been made abundantly clear how critical it is for different IACC communities to collaborate. To discuss this further, we've gathered a wonderful group of experts and those with lived experience here today to share some thoughts. That includes Ms. Karen Bischoff, who's the ICUE project chair, and who also is a founder and president of the COVID-19 Longhauler Advocacy Project. Dr. Peter Rowe, who's a professor of pediatrics at the Johns Hopkins University School of Medicine and the director of the Chronic Fatigue Clinic at Johns Hopkins Children's Center. Dr. Svetlana Blichstein, who's the director and founder of Dysautonomia Clinic and a clinical associate professor of neurology at the University at Buffalo Jacobs School of Medicine. And then last but certainly not least, Ms. Lorraine Johnson, Chief Executive Officer of LymeDisease.org and the principal investigator at My Lyme Patient Registry. So welcome to our wonderful group of panelists. I'm going to stop sharing my screen now so that way we can really center on you and your thoughts as we dive into this really important topic today. So to get started, I'd love it if each of you could give a brief 30-second introduction to who you are and your work and background. I'll just go across as I see you on my screen. So Karen, would you like to go first?
Hi, everybody. My name is Karen Bischoff. I am the founder and president of the COVID-19 Longhauler Advocacy Project and co-founder of the Long COVID Alliance. I served as chair for this project on the committee for the National Academies developing the definition for long COVID, on Recover's Ancillary Studies Oversight Committee, and I am a long COVID patient from March of 2020 and former firefighter paramedic.
Thank you, Karen. Dr. Rowe, would you like to go next?
Sure. Thank you for the invitation. I'm a pediatrician, general pediatrician who in the early 1990s, noticed the association between orthostatic intolerance and those with what we then called chronic fatigue syndrome. Was impressed by the number of patients that called asking for consultation after our first couple of papers were published, and have been doing ME/CFS work ever since for really the last 30 years. So that's my clinical and research focus.
Thank you so much, Dr. Rowe. Dr. Blitzstein?
Sure. So I'm a neurologist here in Buffalo, New York. I started this autonomia clinic 15 years ago, concentrating primarily on autonomic disorders, POTS, and now long COVID. And I have seen patients with all kinds of neurologic manifestations of infectious syndromes. And I am doing research on POTS and autoimmunity, immunotherapy, and women's health, and how it affects pregnancy, postpartum, and the sexual function of women with autonomic disorders and hypermobility spectrum disorders. So since long COVID, of course, naturally, I have seen hundreds of patients, published papers. We were the first one to publish a case series of patients with POTS and other common autonomic disorders after COVID infection. It's a great honor for me to be here. Thank you for doing this important work. I think there were decades leading up to that moment where we can all gather and say, what can we do to improve this problem? If we can't find solutions, what can we do to improve the quality of life of patients living with post-acute infectious syndromes?
Thank you, Dr. Blitzstein. And last but as I said, certainly not least, Ms. Johnson.
Hi, I'm Lorraine Johnson. I'm a recovered persistent Lyme disease patient. I'm the CEO of the LymeDisease.org, the largest communications network for Lyme disease. I'm also the principal investigator of the My Lyme Data Patient Registry, which has enrolled over 18,000 patients and published 6 peer-reviewed journal articles. I served on the planning committee for the first National Academies event on infection-associated chronic conditions, which brought researchers from persistent Lyme disease, long COVID, and ME/CFS together for the first time. By profession, I am an attorney with an MBA.
Thank you so much, Lorraine. Well, let's just dive right in. We've got some great questions for you today, so I'd love to get started. First, I'd like to start with Dr. Blitzstein. Different IACCs have more in common than most people realize. I think that much is very clear. In your view, what are the most important commonalities that exist between IACCs?
Right. So, with long COVID, a lot of doctors are now learning about the syndrome, and it's very new to them. It's not new to many of us who have seen these patients over a period of many decades. So what is common? Well, the first thing that's common is autonomic dysfunction that's present in at least 70% of patients with long COVID. The other thing that's very common is an ME/CSF phenotype that is present in at least 50% of patients with long COVID. Then we venture into, well, what else? What else is the joint hypermobility as a feature, and hypermobility spectrum disorders as potentially pre-existing conditions that many people didn't know about. So many people had some maybe aches and pains, some migraine headaches, maybe some allergies. And when COVID hit, now they develop this full-blown syndrome. In many of these patients, there is a history of something that suggests that they may have had hypermobility spectrum, and it's a spectrum. There are people who are superior athletes. I always use the example of Dr. Rowe when I heard him at a lecture, when he said that athletes have a very high scale. I'm not naming specific athletes, Dr. Rowe, but you know who I'm talking about. And you said they have like 9 out of 9, and they're functioning very well. So it's a spectrum. There are hypermobile people who are very athletic, and there are people with hypermobility who are very sick. So it's a kind of a non-specific sign. But what we know from more than one study now is that patients with long COVID may have hypermobility, and that people with hypermobility and hypermobility spectrum disorders may be at risk for long COVID. And then we have that other common category is mast cell activation. or mast cell hyperactivity that could predispose people towards long COVID. So those are the 4 common things that I see. There are many others, but the 4 common themes that we see common to all post-acute infectious syndromes.
Thank you so much, Dr. Blitzstein. And, Ms. Johnson, I'd love to get your thoughts on that question as well, kind of from the seat you are at LymeDisease.org and kind of your background. Are there any other common threads or commonalities you'd like to elevate when it comes to IACCs?
Yeah, I think there are a couple. Some of the symptoms that we believe are overlapping among these conditions are fatigue, sleep problems, cognitive difficulties or brain fog, headaches, sensitivity to light, sound, and temperature, peripheral nerve issues such as small fiber neuropathy, muscle and joint pain, dysautonomia, which was mentioned, vascular problems like blood clotting, heart issues such as blockages and heart attacks, and then post-exertional malaise, which is common in ME/CFS and long COVID and in some Lyme patients. I think there are other things that these diseases share in common that really have to do more with the conditions for diagnosis. So, we know that these are conditions that arise from an infectious illness that hasn't been resolved. And a major challenge is the lack of reliable tests or biomarkers to diagnose patients. We don't know why some patients remain ill, and it may vary for different people. Potential causes include ongoing infection or an overactive immune response. Patients are frequently misdiagnosed or have their symptoms wrongly attributed to mental health issues. Many are treated dismissively when they seek professional care. Gaslighting is unfortunately common. These diseases are sometimes considered contested diseases, meaning that some doctors and some researchers dispute their existence. So many patients seek treatment outside of typical healthcare settings, which may not be covered by insurance. And often these patients are forced to either bear the medical costs themselves, paying out of pocket, or forego care altogether. Patients have a difficult time finding clinicians who will treat them, and many travel great distances for care. And as we all know, treatment options are very limited.
Absolutely, Ms. Johnson. And I think that's a really great dovetail into my next question for Dr. Rowe. You were just mentioning diagnosis and the challenges that come with diagnosis. So Dr. Rowe, I'd love to get your thoughts on what the most significant challenges are regarding diagnosis and also treatment of IACs. And how can healthcare systems adapt to meet these challenges? What are the things you'd like to elevate from your perspective?
Well, as you heard from Lorraine and Svetlana, there are a long list of symptoms that people come in with. I like to tell our trainees that it is a monotonously consistent group of symptoms that they present with, not a random collection like you'd see in some kinds of psychosomatic disorders. So the consistency is important, but it's a long list. And so it takes a long time to unpack the details of that person's story in order to come up with a decent therapeutic plan. So our healthcare system is not set up well to deal with that kind of complexity. So we need longer appointments. You cannot handle this in a 15 or 20-minute appointment. And so the poor practitioners whose office managers are asking them to see people every 30 minutes, which is probably a luxury in some practices, just can't get the stories squared away unless they have consecutive clinic blocks. So we have to come up with a better way of funding healthcare so that it can take care of people with this level of complexity in proper detail. So that's a big issue. The other thing is that there's still some lingering comments in medicine that if you've got more than 3 symptoms, you must have a psychosomatic disorder. Well, that's clearly blown out of the water by all of these infection-associated conditions. They all have multi-system involvement because of the autonomic involvement that Svetlana mentioned. And so, again, we have to kind of adapt to complexity and figure out better funding mechanisms for supporting clinicians who do this kind of work.
Thank you so much. That's really helpful. And, diagnosis obviously is a critical piece of the puzzle. The other critical piece of the puzzle comes when we discuss treatment, right? How do we support individuals living with these IACCs? And so this next question is really for Dr. Blitzstein and Dr. Rowe. In your clinical care practice, and all of the IACCs that you've seen, and given the commonalities we've already established today, what common physiologic treatment approaches do you find across IACCs? What are we already identifying or finding as clinicians that work across conditions? Any thoughts?
Yeah, so, a lot of the times my colleagues in neurology and primary care tell me, well, what do you treat them with? You diagnose them, and then what? There is no treatment. And it's true that there is no treatment. There is no FDA-approved treatment for long COVID or ME/CSF. There is no FDA-approved treatment for POTS either. But we can do a lot of things because we have medications. A lot of them are old medications that are safe. A lot of them are medications that we use in pediatric populations that can be very helpful in terms of reduction of symptom burden and improving quality of life. So what do we have? Well, first of all, how I treat patients is I first need to identify if orthostatic intolerance is present. So I always recommend a 10-minute stand test. That's very easy. You don't need a tilt. You don't need special equipment, just a blood pressure cuff. And your medical assistant, my medical students do those. It's not hard. And then I establish whether there is a change in blood pressure and heart rate. However, I do want to caution that this is not an absolute marker, and that many patients may have a normal blood pressure and heart rate variation, yet they're still sick. So on one hand, it's almost like we recommend doctors do that. On another hand, we tell them, well, it's not really specific. Yet we still need to do that because it can uncover a postural tachycardia, or it can uncover a falling blood pressure. Once we do that, we say, well, what do we have for treatment of autonomic dysfunction? And we have first-line medications like beta blockers. We have vasoconstrictor like midodrine. We have volume expander like Florinef. We have an ion channel blocker, which is avabradine that decreases the heart rate. We have Mestinon or pyridostigmine, which is an old myasthenia drug that can be very helpful for autonomic dysfunction, POTS, long COVID, and orthostatic intolerance in general. We have stimulants, ADHD drugs, Adderall, Ritalin. We have Vyvanse. We have certain antidepressants. Now, antidepressants is not my first line treatment, but we can certainly utilize them. For example, bupropion, Wellbutrin can be helpful for fatigue. We also have an FDA-approved medication for neurogenic orthostatic hypotension, which is droxidopa. Then we have a category of drugs for neuropathic pain. Those are your gabapentin, amitriptyline, nortriptyline, pregabalin. We have low-dose naltrexone. This is a drug we've used for many years for chronic joint pain. And now with long COVID, and thankfully researchers from big institutions are now taking notice and running studies and proving exactly what we've anecdotally seen, that these drugs are safe. It's a compounded medication. It's not even a drug from the pharmacy, and can reduce neuropathic pain, joint pain, and fatigue. Then there is a category of treatment for mast cell hyperactivity. Once again, those are many of them are over-the-counter medications that you don't need a prescription, but you should certainly discuss it with your doctor because there are some contraindications and considerations. And those are your over-the-counter famotidine, loratadine, Zyrtec, Allegra, all other ones that can be very helpful in reducing mast cell hyperactivity, which may not be a disorder for all patients, but is certainly one of the mechanisms that is at play with inflammatory conditions.
Thank you so much, Dr. Blitzstein. Dr. Rowe, anything to add to that topic when you're looking at kind of cross IACCs and what has been working so far?
Yeah, I think I would agree with everything that Svetlana mentioned. In our work with pediatric ME/CFS, 100% of the patients have orthostatic intolerance to some degree. In the adults, it was thought that it was only 40% at the time we wrote the Institute of Medicine report in 2015. But we have colleagues in the Netherlands who've done very nice brain blood flow studies that show that of the adults with ME/CFS, 90% have a significant reduction in brain blood flow when they're put upright. Only about 40% of them, the same number that we published in the IOM report, have confirmed heart rate and blood pressure abnormalities. The other 60% have normal heart rate and blood pressure, but they still have a 24% reduction in brain blood flow. So treating that is key. We also, in addition to the things Svetlana mentioned about focusing on PT for the people with joint hypermobility, 30% of our pediatric patients have a milk protein intolerance that probably overlaps with the mast cell activation. They don't know that they have it. They have epigastric pain, reflux, early satiety, and they improve when they go off milk. And then the last thing that we focus on with our physical therapy colleagues is that many people have restrictions in range of motion despite their hypermobility. And those things need to be treated. They can have thoracic outlet syndrome where they have difficulty with the arms overhead. They have lots of myofascial tightness and spasm. And treating them gently with manual physical therapy can be something that is a bridge to improved tolerance of activity. But it is a complicated mix of comorbid conditions. And I think that's part of, again, why it takes so much time in the clinic.
Thank you, Dr. Rowe. And obviously what's becoming very clear through our conversation today is just that there are so many common threads and there are so many common themes, even though, of course, every individual has their own unique lived experience in their conditions. That lends us obviously towards looking forward, right? You've already brought up, research that is starting to be done, as Dr. Blichstein just mentioned. So the next question I have is for Lorraine. Ms. Johnson, what is the benefit of IACC patients in cross-condition research or research conducted with multiple IACC cohorts? What are your thoughts there, given your lens?
Well, I think the value of cross-condition research can best be seen through the lens of the 2023 National Academies Workshop, which was funded by the Cohen Foundation and the CDC. And this event was groundbreaking because for the first time, researchers from different fields, long COVID, persistent Lyme disease, and ME/CFS were brought together in the same room to collaborate. I was on the planning committee for this event and made sure to include patient-centered researchers and also developed a panel of patient-led research that represented all three conditions. Lisa McCorkle and I were both on that panel. What was really remarkable was seeing how researchers from different fields began noticing similarities between the conditions and started forming new research ideas. They also started building the communication connections necessary for future collaboration. At the last meeting of this, IACC group, I remember one patient saying, "Let's talk about the elephant in the room, small fiber neuropathy." And this is a condition that affects each of these diseases. It's a loss of small fibers in the feet and hands that is quite painful. So I was delighted to see that one of the research projects that arose from the National Academies event was a study on small fiber neuropathy in long COVID, persistent Lyme disease, and ME/CFS. This research was funded in part by the Cohen Foundation, which has been a big supporter in Lyme disease. And it showed that bringing these groups together could spark important new research. I spoke with another researcher recently who is looking at brain changes in patients with persistent Lyme disease on long COVID. So the point is that these types of events where you bring people together in particular can have an enormous effect. And they can have an enormous immediate effect, as in one researcher calls the other researcher, or they can have the effect where it just becomes part of the milieu. I mean, I think when I was talking with a neurologist who was talking about brain changes in these conditions, she was very interested in this, but I don't think it was because of the National Academy event. It wasn't something that this person attended. So it's getting that type of research going that I think is important.
I really appreciate that, Lorraine. That's very helpful. And you know, speaking of research and speaking of kind of expanding our knowledge and looking forward, a common thing we often hear about is our biomarkers, right? The search for biomarkers. So I'd like to kind of open this up to the panel here. When we're thinking about biomarkers, are we going to have them? Should we wait for them? If we do wait for them, what should we be doing in the meantime? I'll open the floor to whoever would like to go first on this topic. Karen, were you raising your hand? If so, I'll give you a shout out for you to go first.
I think biomarkers could provide objective measures for diagnosing these conditions and tracking disease progression and tailoring treatments. But the reality is that that can take a really long time to do. So what do we do in the interim where we improve, patient quality of life? I think it's important to remain helpful and continue to bring our communities together to advance and speed up our access to biomarkers. But in the interim, we have to do a lot of what Dr. Blitzstein was talking about, which is treat what we can and improve patient quality of life, allow patients to perform better in their activities of daily living and just regain parts of who they were. That's not the solution overall, but it's what we have to do in the interim. And we have to continue fighting in the interim for more research and for more programs that can bring infection-associated chronic conditions to the forefront. One of the things that I really, really want to emphasize is more in the now. Like the best form of treatment is prevention, right? We're still very much in a pandemic. We're talking about COVID, developing long COVID, people can be masking. The same thing goes for many of these other conditions that were triggered by infections, right? The best form of treatment is prevention. And I just want to hammer that in for a second and bring us back to the very things that are triggering these conditions.
Thank you, Karen. I think that's so important. Sorry, go ahead, Lorraine. Would you like to add to that?
Yeah, I'd like to add to that. I think all of those things are absolutely important, Karen. And in the Lyme community, we have waited 20 years on biomarkers with no improvement, no treatment options provided. So I actually am, I believe that it's important to address the symptoms, but I also believe it's important to address the cause. And I don't think we're going to get there by doing randomized controlled trials because they take too long, they exclude most people, and they're expensive. So, what I think needs to be happening is we need to see more clinical innovation in providing treatment aimed at curing. In Lyme disease, we have some clinicians who are treating patients with different antibiotics, different approaches that would be appropriate for the type of infectious agent that cause the etiology here. And there are patients who have gotten well. And we know this because we have a patient registry where we've asked patients who are well, what did you do? So that we can see what they did that made them well. So I think, there's a role in here for patient communities to be doing things through patient registries that help to advance our understanding of what is working for patients. Patients are experimenting, and we need to capture that data, analyze it, bring it forward into the public conversation.
Thank you so much, Ms. Johnson. Totally agree. Dr. Rohr-Blitzstein, anything to add? And if not, I'll jump to the next question.
I want to quickly add that these are very complex disorders. And what everyone is going to learn now is that there is no one size fits all. And when we say that we have to wait for this elusive, anti-infectious agent and it will cure everyone, I don't think that's going to happen. Similarly, when we say, is there an immunotherapy that's going to be great for all? That's not going to happen either. So we will see subsets of patients, just like Ms. Johnson said, some will respond to perhaps longer courses of antibiotics. Then you'll have patients who don't. And I see them after they've been on Lyme treatment, they come to me and say, what now? I'm still sick. What's going on? Then I try to address their autonomic dysfunction that was to the best that I can. So I think to summarize this very important issue, these are very complex problems affecting the immune system. We know that the immune system is very complex, knowledge is evolving, and that we will have subsets. So I always say that we need many tools in our therapeutic toolbox, because then we'll have to decide as clinicians which medication, which IV treatment would be best for a specific patient population.
Thank you so much, Dr. Blitzstein. I think this leads a great time to kind of dive into collaboration, right? Working together. So Dr. Rowe, I'd love to get your thoughts. How can collaboration across IACC organizations help to meet the needs for pediatric-focused educational materials for parents and primary care providers? Any thoughts there?
Yeah, we a group of us that was brought together by Ken Friedman a number of years ago put together an ME/CFS primer for pediatric patients. It's an open access document, free of charge to download. It's got about 40 pages of detail about the diagnostic approach and the treatments and the doses for different medicines, along with things like accommodations for school. That document has been the basis of anything that we've published on the same issues in long COVID. So these things overlap. There's an efficiency involved there. You don't have to reinvent the wheel. Unfortunately, I think in the long COVID space, many people new to that area really were insistent that they don't deal with the baggage and the bad public relations that came along with ME/CFS in the past. So they wanted it to be completely different, and I think that was a mistake. And they're now coming around to realizing that hypermobility is a risk factor, autonomic dysfunction is common, mast cell activation is there and treatable. So I think this collaboration can also improve the educational materials that we have available.
Thank you, Dr. Rowe. And Dr. Blitzstein, I'd love to get your thoughts kind of in a similar vein. What can IACC organizations working together do to increase primary care provider recognition of dysautonomia in IACCs? Oh, you're muted, Dr. Blitzstein.
Okay, that's a great question. And where do we, as Emily was saying, there was a workshop on what are the goals and dreams that we have for these disorders. So what goals and dreams I have, and many of my colleagues have, is that the ME/CFS, dysautonomia, and now long COVID are going to be viewed, recognized, and have treatment pathways as a primary care problem. So in the same way as the primary care physician treats diabetes or high blood pressure or asthma, now these disorders need to come into play, because we have no luxuries anymore of saying, oh, this is too hard, this is for the specialist, or I'm going to take the easy part. Now, with millions of people affected by long COVID, every physician will have to be in on it and will have to learn. Now, how can we all help? Well, by having CMEs, by having training in medical school, in residency, and then at every major society, AMA, our American Academy of Neurology, we all have to have courses on long COVID and related disorders, or post-infectious syndromes that include dysautonomia and ME/CFS. That's what I see happening, and it will require investment of funds first and foremost, but also resources. It will require collaboration from the top, from the top academic establishment down to the people in the field, in the workforce, in primary care.
Thank you, Dr. Blitzstein. We've got time for about 2 more questions, I think, before we'll invite the LCA team to join us for a broader Q&A. But Ms. Johnson, one final question I have for you is, how do we reconcile cross-IACC research with the necessary and specific research that does need to happen for individual conditions? How do you kind of look at that picture?
Well, the way we view it is that it's two-pronged. It's not a this or that. It's actually using a combination of both where it's appropriate, and using a single disease approach where that is appropriate. So some of these diseases have different etiologies, and those etiologies may lead to types of research that can help resolve the problems there. That type of research is probably best conducted by the individual diseases. And then some of these things that we are talking about, like, for example, dysautonomia, small fiber neuropathy, a lot of these crossover areas, these are really sort of ripe for having multi-armed studies, so that you have a study that's looking at this group, and it's subgroups, right? So you have a subgroup that's long Lyme disease, you have a subgroup that's long COVID, you have a subgroup that's ME/CFS, and you look at those to see, are these conditions actually sharing some of the same symptoms, so that we have a better understanding of what's going on in terms of mechanisms.
Thank you so much, Ms. Johnson. And last, kind of thinking about today, how are we supporting patients today, individuals, caregivers? My next question really goes to Karen. So the LCA team, along with other patient advocacy organizations, are working on a resource guide to support individuals living with IACCs across conditions. So as an individual with lived experience of navigating an IACC, what value do you see in such of a guide?
I mean, cross IACC research and cooperation among patient organizations offers tremendous potential benefits for the entire community of all people living with IACCs. And when we as communities and advocacy groups work together, it allows us to pool resources and share knowledge and identify commonalities across all of these conditions that might otherwise be overlooked if studied in isolation. So part of the process of what we've done through this, we've been collecting resources and information from many of the stakeholders that have been involved. And we've been developing this resource guide that includes a lot of the critical things that our patient communities need help with, like preparing for doctor's appointments, understanding, the basics about these conditions, locating provider recommendation lists, and all of these types of things that even experienced people in the IACC community still haven't had resources for a long time. And I think that, I'll speak from the long COVID perspective, where there's so much under the long COVID umbrella, right? Autonomic dysfunction, ME/CFS, MCAS, fibro, myocarditis, all migraine, all of these other different things is very taxing on patients. And it's hard to learn about one condition and manage one condition, let alone managing many, which many in the IACC community have. Many don't have just one IACC, unfortunately. They develop a grouping of them. And I think having a resource to point to, not only for yourself as a patient, but for your caregivers, for friends and family who are looking to understand better, even for your clinician to understand the basics and get them interested in looking into these things. Like you've heard our clinicians talk about today, a lot of clinicians kind of throw their hands in the air and say, I'm not sure what to do with you, go see a specialist, but they don't realize that there really aren't specialists to access. So having a starting point for the patients, having a starting point for clinicians, and helping us continue and build off this momentum in IACCs is really where we're trying to go, is this is the foundation for people.
Thank you so much, Karen. I think that's a really great kind of final point for us to chat on as a panel. So I'd like to say thank you, first of all, to all of our panelists. This was a really wonderful discussion. I think we could have kept going for another hour, honestly, with all of the various topics we need to touch on. But before we go, I did want to welcome the LCA broader team members to join us on the panel stage, if you will. It's just, we have a few questions that we'd love to go through from the audience. I think we actually have time for one or two more before I turn things over to wrap things up. So the questions we have here, I believe this is for Emily. Emily, are you spotlighted yet? I just want to make sure you're...
Hello, I'm here.
Perfect. Okay, great. So one question we got from the audience is, can the panelists please discuss the choice of language? Why IACC versus IACI? Should those be using IACI, be switching to IACC, and then vice versa? The person wants to understand how different communities are evolving and adapting this language. And are we even all on the same page? So I'd love to get your thoughts on that, Emily.
Absolutely. That is a critical question and something that did come up during our workshops and our panel discussions. One thing that for those of you who don't know me, I've been in the ME/CFS community since 2008 when my mother got sick. And so I've been here a while and I've seen a lot of evolutions of terms. We even had CFIDs back in the day. But one thing I found that was really interesting was when we really opened up the stakeholder community and said, which terms do you prefer? Folks pushed back about the term illness because they said illness has the assumption of an end. Illnesses end. And so a lot of folks felt that this is more condition, felt like a more appropriate term because it did not imply an ending, whereas illness seems to imply that somehow this goes away. So that's why we really emphasized chronic as a term that we absolutely needed to have centralized. And infection associated, we had some people propose post-viral, other folks had other terms, but infection associated really captured the holistic experience and also some of the theories about viral reservoirs and the persistence of viruses. So we wanted to be both scientifically accurate and reflective of the community preferences. And that's a hard line to walk. So we definitely hear you IACC, IACI, IACCI. There's a lot of different terms out there, but we just wanted to be reflective of really that that key element of these terms. This experience is common. It's associated with infections, especially COVID, as sort of the launching point of the dialogue with the LCA, but then we expanded out following the science to where all those different corners lay. And then lastly, just the overall experience of the commonality of our shared experiences, both in medical care, in our physical symptoms, our caregiving challenges, all of those different pieces. So absolutely, I just wanted to thank folks for bringing it up and can keep your conversations coming. Like, this is not an endpoint dialogue. This is a living process. And as new information comes out, we need to adapt and change. And as new families and friends and allies join us, their opinions need to be incorporated as well. So we're not locked in stone. We feel that this is a strong term that envelops all of the feedback we got, but more feedback is coming. So I'll just say the email address, contact@iaccpac.org. That stands for IACC Patient Advocacy Coalition. That's a temporary name, but that email address is operational. So please give us your thoughts. We'd love to hear them. And if you really feel strongly that this term is in the wrong direction, we need to hear that too. But so far, based on the workshops that we've had over the past year or so, this has been the term that's really bubbled up to the top as a commonality of the experience.
Thank you so much, Emily. I think that was a really important kind of final thought about how obviously the explanation you just gave, but also just reiterating we're consistently learning. The team wants to hear from the community. We want to understand your thoughts and your needs. And so to that end, we are nearing the end of our time together today. So unfortunately, that is the last question we can take, but we do want to acknowledge all of the wonderful questions we did get in the Q&A box today. Please, if you have a question, feel free to submit it now anyway. I know I can speak on behalf of the LCA team that we will review them. We will be thinking about them, particularly as they are finishing the resource guide that they're going to talk about in just a second. And to the extent there are, individual follow-ups that might be possible, we'll be happy to take a look at that. So, so with that, I'm going to go ahead and share my screen for the last part of our presentation today and turn things back over to Emily and Lucia. So with that, take it away, Emily and Lucia.
Thank you so much. As we conclude our webinar today, just we as the ICUE and LCA team and me personally, I really want to express my heartfelt gratitude to all of you for joining us, whether you contributed through a workshop, whether you just joined us here today, whether you're just for the first time hearing about this effort. We're so excited to have you in whatever form you've come to us in. And thank you for joining us and for your attention. We really are excited to work with all of you. As we stand at the forefront of an urgent and necessary mission implicating so many lives and livelihoods around IACCs, we are acutely aware of the profound impact of support and cooperation, collaboration, that all of that is essential to our coalition's ability to advance research, to advance education, and raise awareness for IACCs. These conditions, plural, affect millions, truly, all over the world and in this country and many others. And yet we still can't explain them entirely. They are misunderstood, underrepresented, underfunded. The clinical situation needs to be improved, as we talked about. So by supporting our coalition and this movement, you have not just supported a group of patient advocacy organizations, but you're standing alongside countless patients who are fighting for recognition, understanding, and effective care. And we hope that our work and this project, as it comes to a conclusion, and as we continue working on it moving forward, contributes to making these diseases hopefully a thing of the past. So with that, Lucia, I'd love to hear your final thoughts and a little bit more about our work.
Sure. I just want to let everyone know that this group's commitment to advancing research and raising awareness of IACCs is a very important mission. We are all acutely aware of the individuals whose lives are impacted by these illnesses, the patients, the caregivers, the friends, each with their own story of struggle and of resilience, and those whose health states have resulted in their being homebound or bedbound. We're especially thinking about them today. We are so proud to represent them as we do this work. They inspire us to work collectively, to challenge established stigmas, and to advocate for the research and resources that all of us desperately need. This is our final webinar within the context of our CDC Foundation supported project, but we very much look forward to continuing to leverage the power of our collective strengths. We have the opportunity to shape a landscape where IACCs are not just acknowledged, but understood, where patients receive compassionate care, and where innovative research and education lead to real solutions and treatments. We thank you so much for joining us and investing in a brighter, more informed future for those living with IACCs. Thank you all for your passion, your dedication, your time, and your belief in this mission. Together, let's continue to advocate, educate, and empower each other. I'm very happy to announce that we are launching our new website. For more information, you can use the QR code that should be appearing on the screen. Thanks, Anne. And we very much look forward to sharing our IACC patient resource guide with you before this year's end. Thank you so much.
Perfect. Well, thank you, everyone. If there's no further thoughts from the team, I'd just like to thank everyone, as Lucia said, on the behalf of the broader team, and thank you for your time today. It's truly been a pleasure to be with all of you, and we look forward to keeping in touch. We'll leave the screen on just for a few more moments so that way people can check out the website as well as scan the QR code. So thank you. All right, everyone. Thank you so much for your time today. I believe that that is the conclusion of our time together, and we hope you have a wonderful day. Thank you so much.